this presentation, our group will be critically analysing the Australian Government's Tackling Indigenous Smoking program, or TIS for short. This national initiative aims to improve the health and well-being of Aboriginal and Torres Strait Islander peoples by reducing tobacco use through targeted community-driven population health promotion activities. The Tackling Indigenous Smoking program was established in 2010 and is funded by the Department of Health and Aged Care. It is made up of several key components, including regional TIS teams, which are funded through regional tobacco control grants. These deliver a tailored mix of culturally safe, evidence-based activities within their local communities. A national best practice unit, which provides tailored support and resources to organisations funded under the TIS program. A national coordinator, who offers policy advice to the Australian Government and provides leadership, support and mentoring to regional teams. This structure allows local organisations, often Aboriginal community-controlled health services, to design activities that best meets the needs of their communities. The TIS program focuses on priority groups such as young people, pregnant women, families and communities where smoking rates remain high. It operates at a national level, reaching urban, regional and remote areas across Australia. The program's wide reach is made possible through its decentralised approach. So, how does it work? Well, TIS uses a multi-pronged approach. Locally funded organisations run education campaigns, community events, quit support and smoke-free initiatives. They also provide training for local staff, like motivational interviewing and quit skills, so people have support to stop smoking. The program puts a lot of emphasis on cultural relevance, using local language, stories and involving Aboriginal and Torres Strait Islander staff in every stage. When it comes to measuring outcomes, TIS looks at a mix of qualitative and quantitative indicators. This includes how many people the program reached, whether the activities were culturally appropriate, and awareness of quit support services. Local organisations submit detailed reports, and national evaluation teams also gather feedback through interviews, focus groups and surveys. They even check quitline usage and national survey data to see if smoking rates are actually dropping. It's important to note that TIS is a tobacco control program, not a smoking cessation program. It aims to reduce smoking prevalence by preventing the uptake of smoking, as well as encouraging people who smoke to quit.
The Tackling Indigenous Smoking program is built upon several key assumptions about how to improve the health outcomes for Aboriginal and Torres Strait Islander people. Firstly, it's built on the belief that tobacco use is one of the most preventable contributors to the health gap between Aboriginal and Torres Strait Islander people and non-Indigenous Australians. With tobacco use accounting for more than one-third of Indigenous deaths, a targeted and community-led response is justified. Although this assumption can sometimes oversimplify smoking as merely an individual choice, rather than acknowledging the deeper influence of colonisation, intergenerational trauma, and ongoing structural disadvantages that continue to shape health behaviours. Secondly, the program assumes that taking a population health promotion approach by focusing on the community engagement, preventing uptake, and creating smoke-free environments will lead to the lasting change. This approach aligns with best practice public health principles and has shown promising trends, yet its success relies heavily on consistent community capacity and sustained funding, which can vary greatly across different regions. The last assumption is that local tailoring and Indigenous leadership naturally ensures cultural appropriateness. This understanding is one of the program's greatest strengths, as it reflects the principles of self-determination and acknowledges that communities are best placed to design solutions for their own people. However, while local autonomy enhances cultural relevance, it can also lead to variation in program delivery and reach to high-risk groups.
Tackling Indigenous smoking demonstrates well-elaborated target audience responsiveness through community-led co-design by local leaders, elders, and community members, ensuring cultural authority and ownership. Place-based flexibility via regional tobacco control grants adapts evidence-based strategies to unique local contexts, whilst innovation grants target priority populations using culturally resonant approaches. Cultural safety operates as an embedded value, with Indigenous knowledge systems guiding development and delivery. Multi-level strategies ensure comprehensive reach from population policies to personalised services, addressing social determinants through system strengthening, policy advocacy, and measuring community empowerment indicators beyond individual behavioural change.
The Tackling Indigenous Smoking program is highly appropriate for promoting tobacco reduction among Aboriginal and Torres Strait Islander people. It directly targets a critical health inequity through culturally safe, community-led, population-level strategies, all of which align with core principles of Indigenous health promotion. Its flexibility allows each region to design locally relevant initiatives, aligning with cultural diversity and community needs, ensuring trust, safety, and ownership within the program. Importantly, the program's adaptation to a holistic prevention framework, combining cessation support, prevention of uptake, and smoke-free environment promotion, results in a more effective strategy than traditional isolated quit programs. This comprehensive approach reflects Indigenous values of collective well-being rather than individual responsibility, recognizing that health is not an individual pursuit, but a shared responsibility grounded in family, community, culture, and connection to country. The program has proven particularly effective in non-remote areas, where access to healthcare and cessation resources is stronger. However, the appropriateness varies by context. In remote areas with limited reach, persistent smoking rates among key groups are still prevalent, suggesting barriers in workforce capacity and resource equity. These contextual disparities highlight the need to address underlying social and economic matters to fully support local initiatives.
The Tackling Indigenous Smoking intervention demonstrates a well-developed and elaborated explanation of multiple health promotion principles operating in synergy. At its foundation lies a comprehensive population health promotion framework that transcends individual behavioral change to drive systems-level transformation. This framework operationalizes 5 core strategies. 1. Strengthening local capacity through partnership development. 2. Advancing multi-level policy change. 3. Creating smoke-free environments. 4. Implementing dynamic health communication via social marketing. And 5. Delivering targeted health education across schools and communities. The program's sophisticated theory of change integrates 3 evidence-based streams of influence. Socially, it systematically shifts community norms and enhances supportive networks through peer influence and collective action. Culturally, it authentically integrates traditional values, practices, and community identity, ensuring interventions resonate meaningfully with Aboriginal and Torres Strait Islander worldviews. And personally, it builds individual knowledge, skills, and self-efficacy. This theoretical mapping demonstrates how strategic service delivery simultaneously elevates individual agency whilst reshaping broader social and cultural norms. TIS exemplifies WISE practice, a methodological approach integrating global research evidence, rigorous local programs evaluation, lived community experience, and Indigenous knowledge systems. This ensures interventions are not only evidence-based, but contextually tailored, culturally safe, and delivered by skilled professionals who respect and amplify community voices. Whilst not constrained by a single theoretical model, TIS strategically incorporates core social cognitive theory elements. It systematically builds self-efficacy through structured skill development, fosters behavioral capability via culturally adapted education, leverages community champions for observational learning, and enables sustained change through supportive environmental modifications and policy initiatives. These theoretical foundations position TIS to deliver nuanced, culturally relevant strategies that achieve sustainable reductions in tobacco use across diverse Aboriginal and Torres Strait Islander populations.
To strengthen the Tackling Indigenous Smoking program, we need to move beyond what's already working and focus on how it could be improved through key health promotion frameworks, namely the Ottawa Charter for Health Promotion, Social Cognitive Theory, and the Precede-Proceed model. First, under the Ottawa Charter's action area of strengthening community action, the program could go further in empowering local communities and young people to lead decision-making. While TIS is community-based, research by Barrett and colleagues in 2023 found that program coverage remains uneven, with weaker reach in remote areas. This shows that not all communities have equal access to resources or support. Applying the Precede-Proceed model's social diagnosis phase, which focuses on identifying what communities themselves define as priorities, would ensure the program evolves from local voices rather than external assumptions, strengthening ownership and long-term engagement. Second, under developing personal skills, the program could enhance its behavioural change focus by drawing on social cognitive theory. Knowledge alone rarely changes behaviour, confidence, role modelling, and reinforcements are what make change sustainable. Studies such as Chamberlain in 2017 and Esterman and Singh in 2014 show that culturally tailored, community-led interventions, including peer support, local champions, and traditional storytelling, significantly improve quit success rates among Indigenous populations. Expanding TIS to include structured quit coaching and youth mentoring could build upon personal efficacy and collective pride. Third, the Charter's principle of reorienting health services reminds us that tobacco cessation should be embedded into everyday care, not treated as an isolated activity. Evaluation of TIS-funded organisations have shown higher rates of smoking status recording compared to non-funded sites, but less evidence of integration across mainstream pathways. Similarly, Aboriginal and Torres Strait Islander people living in TIS areas are more likely to use quitline services, yet overall uptake remains low. Strengthening cross referrals and embedding cessation support into routine health checks within Aboriginal community controlled health organisations would align with a settings based approach, ensuring consistent support where people live, learn, and receive care. Fourth, the Charter's goal of building healthy public policy calls for deeper action on the structural factors that drive smoking. Chamberlain and colleagues highlight that inequities in housing, education, and employment continue to shape tobacco use even when cessation programs exist. Embedding TIS within a health in all policies framework would align it with these broader social determinants and reflect the policy and administrative phases of the Proceed model. Finally, the principle of creating supportive environments can be strengthened by expanding smoke-free community events, workplaces, and healing programs co-designed with elders. This approach not only protects non-smokers, but also fosters community norms that reinforce individual behavioural change, the very definition of a supportive environment envisioned by the Ottawa Charter.
As you can see on this slide, the smoking rate has declined significantly. However, the prevalence among Indigenous Australians remains nearly 3 times higher than that of non-Indigenous people, which is around 10.5%. This shows that while progress has been made, there is a still significant gap that needs continued effort. By 2023 to 24, TIS achieved complete national coverage for the first time, including remote regions. If looking at the data, smoking dropped sharply in non-remote areas from 40% down to 27%. However, in remote areas, the rate stayed high at around 53% in 2022 to 23. So most progress is happening in non-remote settings, while remote communities continue to experience higher smoking rates. So this slide shows target groups of tackling Indigenous smoking. For pregnant women and families, the focus on promoting smoke-free homes and cars to protect babies and young children. And also for young people, the program provides education in schools and community settings to encourage smoke-free and vape-free lifestyles. And for remote communities, programs are delivered through Aboriginal community-controlled health organizations to ensure that cultural safety and local relevance. But there are still challenges. For example, many families continue to face exposure to secondhand smoke and vapor, which affects unborn babies and children. Also, young generation is rising rapidly, driven by marketing and peer influence. And in remote areas, services access remains in a major barriers, contributing to slower declines in smoking. One of the major strengths of TIS is that it's community-led. Programs are delivered through Aboriginal community-controlled health organizations, which builds trust and engagement. So some studies shows that Indigenous health outcomes improve when services are locally managed and culturally appropriate. Another strength is culturally tailored messaging, which means that campaigns are developed in local languages and reflect community traditions. And program also demonstrates equity-focused targeting, prioritizing vulnerable groups such as young people, pregnant women, and those in remote areas. So which aligns with World Health Organization's global tobacco control strategies. And finally, TIS has shown adaptability. For example, during COVID-19, many organizations shifted to digital campaigns and social media outreach to keep communities engaged in smoke-free messages. Tackling Indigenous smoking still faces some limitations. First, smoking disparities remain high. Second, the program's impact is uneven because most reductions has been seen in non-remote areas with small changes in remote communities. There are also funding and evaluation challenges. So tackling Indigenous smoking has been extended only until 2026 under the Department of Health Tobacco Control grants. While this shows continued government support, short-term funding cycles make it difficult to plan long-term strategies and sustain behavior change. Another limitation is data and evaluation. Program results rely mainly on ABS national health surveys. So surveys are based on self-reporting and they are occur every few years.